Well, thank you very much, Binay, for the invitation to come back and speak about AML. My disclosures are mostly related to clinical trial support and then laboratory research for antibody-based treatments for AML, which I only going to briefly talk about. So when you look back in time, AML in the last 40 years, there's this event in 1973 where this combination therapy of cytarabine and an anthracycline, commonly known as 7+3, was introduced. And since then, there's really been a notable lack of any new drugs. In fact, in the last 20 years, I think there's been 2 drugs approved, one of which has since been withdrawn from the market. But this is a year where I think we can be pretty confident that in the next 12 months or so, we're going to have probably at least 2 new drugs that will be approved for this disease. What has changed over time, however, is our ability to support patients through these intense chemotherapies, especially with new antibiotics and better transfusional support. There's been advances in hematopoietic cell transplantation. And probably largely because of those advances, there's been a gradual improvement for many patients with regard to outcomes. But what really has changed dramatically in the last maybe 5 or 10 years is our knowledge of the genetic basis for AML. And maybe the study that has brought this most to the forefront of our minds is a TCGA network effort that has sequenced 200 patients with de novo AML and described in those patients that on average there's between 10 and 15 mutations there. Many of these mutations are in genes that are commonly mutated, and they came up with a list of about 260 mutations or genes where at least in 2 patients a mutation was found, and a smaller set of somewhere in the range of 20 to 25 genes where mutations are really commonly found, and those are sort of depicted there. And when you put this together for patients, it really has become very clear that the landscape is very complex, and essentially every patient has a unique type of disease. And you can nicely graph this with these pie charts, and you get these like smaller and smaller little pies as you go finer with splitting them up into mutational entities. And I think given all these sequencing efforts, we've now identified all mutations that are at least occurring in 1 or 2 or 3% of AML patients. So I think the universe of mutations in AML is now described. And I think it is now the time that we have to start making sense out of what this universe actually means. And I think this in the clinic becomes very relevant because more and more patients have their leukemias either sent for sequencing or for sort of gene mutation profiling, and they come back with a printout of a number of mutations, and the question is, hey doc, what do I do with this? And I think this is a real work in progress. There's a few things that we know, and there's many things that we don't know. The few things that we know is that not all mutations are similar. There's some mutations that are recognized to be very stable over time and are therefore sort of suitable to track a disease over the course of a patient's life and disease. And the most relevant ones in these days is NPM1 and then the mutations associated with the core binding factor leukemias. There's other mutations that we know very well. They are not uncommonly lost or gained over time, and a classic example are the mutations in FLT3. And then there are mutations that exist even though a patient has been disease-free for many, many years, and one would think the patient is cured. And probably largely underlying these phenomena is the fact that AML is a multi-step disease process where it takes several hits before a leukemia is really present as a fully developed disease, with some mutations that occur very, very early in sort of pre-leukemic cells that may then last over the disease course and can be found in patients that seemingly have returned to normal hematopoiesis. And it's also recognized that the disease evolves very variably between patients with multiple clones being present at disease, and then some of these evolve and become dominant when a disease returns. And some of the mutations, primarily those that are acquired later in the disease process, can then be lost as a disease clone disappears, or another one can emerge as a new clone shows up. We've also learned a great deal about what these mutations mean with regard to prognostic significance. There's an increasing number of mutations for which we know that they have a significance with regard to prognosis. I underlined the most important ones today, which is the NPM1, the double or the biallelic mutation CBPA, and abnormalities in FLT3, in particular when there are internal tandem duplications. But there's an increasing list that we will hear more in the next several years, maybe the most dominant ones being mutations in P53, RUNX1, and ASXL1. There's mutations that we commonly hear about because there's some drugs being developed for them where we really don't quite know how significant they are from a prognostic standpoint. In part, that may be because it has become clear for some mutations, and it sort of becomes clear for others as time goes on that the impact of mutations may matter in which context they arise. For example, an IDH1 mutation may only be relevant if it occurs, or prognostically relevant if it occurs in the setting of another mutation, but may be less relevant if that mutation is not present. It matters which exact mutation it is. There's point mutations, for example, again in IDH1, where there's a clear thought that this is related to prognosis, and other point mutations don't seem to matter very much prognostically. And it matters which patient age we're talking about. That's now recognized for NPM1, for example, where we commonly think that's a good prognostic marker, but recent studies done in samples from patients treated in SWOG trials have indicated that if a patient is older than age 65-ish or above, the impact prognostically really becomes very, very minimal. What we've also seen very recently, and this may become relevant for Dr. Ravandi's talk later on, is that certain mutations are very specific for secondary leukemia, so leukemias that arise from a antecedent, either MDS or NPM1, and those mutations are only or almost exclusively found in those diseases, and may allow us at some point a more genetic diagnosis of secondary AML versus de novo AML. These mutations are now used to sort of refine our risk stratification tools, which traditionally have been really based on genetic changes. Here on the slide, I've listed the current scheme from the European Leukemia Net, which probably is the most commonly used classification scheme in these days that we use, that integrates the classic genetic abnormalities that we've known for many decades, and adds information on FLT3, NPM1, and CBPA. And there's going to be, or studies have shown that when you treat larger amounts of patients, that you can separate out treatment outcomes relatively nicely depending on the risk group that a patient falls into based on the genetic or molecular profile. The ELN is about to release a updated version of their general guidelines on how you treat AML, and the paper is probably going to come out sometime early next year. And most likely, there's going to be a revision of this classification scheme that will integrate additional information such as the burden of FLT3 ITD, commonly known as allelic ratio, or the genetic entity of a monosomal karyotype, which is now recognized as a very, very treatment refractory type of leukemia, and then additional mutations such as ASXL1 and RUNX1 or P53. So this is really kind of a work in progress, and there's probably going to be modifications of these schemes over the next many years to come. But it's a sort of a common realization in the clinic that a patient that you think based on genetic markers should do very well, has an early disease recurrence and dies from recurrent or refractory disease. And on the other hand, you have a patient that you would have thought, based on genetic markers, would not do well, but goes into remission and stays in remission for a very long time. So these pre-treatment risk stratification factors, they work for large numbers of patients as cohorts, but they really have limitations for individual patients. And we've recently done sort of the exercise to do this mathematically. And when you approach this mathematically, you can show that the ability to predict treatment outcomes based on these pre-treatment markers plus many others that you can integrate are limited. So this raises the question, are there things that we can learn as the treatment goes on with regard to how a patient will do? And one thing that has become very in the forefront of a lot of discussion is this idea of measurable residual disease, or previously known as minimal residual disease. So small amounts of leukemia identified either by multi-parameter flow cytometry or molecular approaches that are present even though a patient is in a morphologic remission defined by having less than 5% blasts and having normalized blood counts. And it's become very, very clear that information on MRD provides a very helpful additional piece of information with regard to prognosis of patients. And I've depicted just two examples, one from a cohort of patients that we treated at the SCCA and the UW. These were about 250-ish patients that did not go on to get a transplant. And depicted on the slide is simply a relapse incidence based on best response. And as you can see, patients that have achieved a morphologic remission but then don't have minimal or measurable residual disease by, in this case, flow cytometry, have a relatively low risk of disease recurrence, whereas patients that have achieved a full remission by morphologic criteria but have MRD present will have very high risk of relapse. Interestingly enough, and I think we don't really emphasize that enough, that we have these sort of incomplete remissions that we talk about a lot in the clinic, patients that are in remission but lack complete platelet recovery or complete neutrophil recovery, and we designate them as CRPs or CRIs. At least in our hands, these patients have very high risks of relapse regardless of whether they have MRD measurable or not, suggesting that this lack of full blood count recoveries is actually telling you something about the biology and the disease risk of these patients. And MRD can be very informative very early in disease course. I think this was first highlighted in ALL, but is now becoming more and more overtly clear in AML as well, that as early as after the first treatment course, whether you have or you do not have MRD present is really going to inform on the future risk of disease recurrence. And where this becomes important is in that it can help you refine your thinking of a patient's risk. And maybe best exemplified is this with patients that traditionally fall into the favorable risk disease category based on genetic or molecular markers. I've shown here two examples. The first one related to core binding factor leukemias, where MRD was detected based on PCR for these translocations. And even though we commonly think of these as very curable leukemias, if patients fail to achieve a very good reduction of translocation burden assessed by PCR early on, they really have very high risks of relapse. It's a small percentage of patients, but it's a very important subset of patients that will not do well. And more recently, and you may have seen this in the New England Journal of Medicine just earlier this year, a very similar finding was shown for patients with NPM1 mutations. Again, especially if a FLT3 abnormality is absent, this is a type of leukemia that we commonly think of being favorable or more favorable. And again, this is shown after two courses of therapy. If a patient still has NPM1 present by PCR, the risk of relapse is really quite high and certainly would not qualify as what we typically would think of a favorable disease type. So with these sort of remarks regarding molecular diagnostics and risk stratification, turning to the actual treatment approach, and I think at the beginning of an AML, or when you meet the patient that just got diagnosed with AML, there's at least two important questions that you have to address. The one is, how intensely do you want to treat the patient? And the second question is, are you going to choose a quote-unquote standard treatment, or are you going to choose a investigational therapy, and is it worth sending a patient to a center that has investigational therapies available? So with regard to the first question, with this improvement in supportive care, the early death likelihood for AML patients really precipitously declined in the last 2 decades. That was shown for patients treated at MD Anderson, and that has been shown for patients treated in SWOG trials. And with that, I think it's fair to say that the main problem in leukemia is not so much the risk for death for patients, but it's the fact that the therapies are not active enough and patients will have resistance to treatment, either upfront or with a recurrent disease after a temporary success. Now the question, what is better to treat the patient with intensive therapy or non-intense therapy, is as important as it is. It's not very well addressed with very rigorous studies. There have been sort of randomized studies many decades ago that have tried to get at this, and there's commonly 3 that people cite, and they came up with 3 different conclusions. But there is some imperfect data, for example, from the Swedish Leukemia Registry, which is a registry that basically encompasses every patient in the country that is diagnosed with AML. And data from there and other data would suggest that a patient that is treated with intensive therapy will do better with regard to survival than patients that are treated with less intense therapy. And that seems to be true even for patients that are older or quote-unquote elderly up to the 70s and 80s, as long as they're reasonably fit, medically speaking. And even though this is not well defined, and I think this has been a problem for drug approval in the past, the ELN again is going to come out with some recommendations of how you should consider a patient unfit for intensive therapy. And the recommendation will be something along the line that one should consider intensive therapy unless the patient is really older and one or more of the following things apply. Either performance status is really poor as a 3 or 4, that's not related to AML, there are really significant comorbidities present, or the patient has an adverse risk cytogenetic profile. So with that, I think a lot of patients would or should be eligible for intensive therapy, and this is certainly different from the current state of treatment in the US, where there is data from SEER and Medicare that about 50% of patients that are older than age 65 with AML don't even get treated in the first place. But then the second important question is whether you want to treat the patient with standard therapy or investigational therapy. And as I mentioned, 7+3 remains a standard for many centers, but the outcomes are not very good for many of the patients with AML. And I think this again leads to recommendations to consider investigational therapy. I think you should consider it for all patients, but particularly for those with adverse risk or perhaps those with intermediate risk disease. So while there's been many years without any clear improvements, there's been a number of things in the last few years that at least show incremental improvements over outcomes that one could accomplish with 7+3 therapy. And the 4 things I'm going to talk about in the next several slides are intensified treatment with high-dose cytarabine-based therapy, escalated doses of an anthracycline, addition of an antibody, and addition of a small molecule inhibitor. And I think Dr. Avanti will then talk about liposomal cytarabine and daunorubicin as a fifth improvement. Now, the MRC, the UK group is really phenomenal in that they're able to accrue many patients in a very short period of time in large trials that, while complicated, are able to address interesting questions in a randomized fashion. And a few years back, they randomized over 1,200 patients to what their 7+3 equivalent is. It's a 10+3 day course of daunorubicin, cytarabine, and etoposide, and FLAG-IDA, which is growth factors, fludarabine, high-dose cytarabine, and idarubicin. And what they showed in this randomized study is that the high-dose cytarabine-based treatment had better anti-leukemia activity. It led to reduced risk of relapse, and it led to better disease-free survival. And the benefit was seen in all subgroups, as much as they were able to tell by their subset analysis. But there also is a problem with toxicity, and there were more people that ran into toxic deaths while in remission. So at the end of the day, the survival or overall survival was not statistically significantly different from their 10+3 treatment. And there's a SWOG study ongoing that actually just closed for accrual that is looking at this question again, randomizing between the SWOG approach of 7+3 and MD Anderson's high-dose cytarabine backbone. And I think some of the data may be presented at ASH of this year, so it'll be interesting to see if what the UK group has seen can be reproduced in the US. A second modification of 7+3 that has raised a lot of interest, at least temporarily, is this idea of escalating the doses of an anthracycline. And around 2010, there's been 3 large studies, one in Europe, one in the US, and one in Asia, that has randomized patients between daunorubicin at 45 milligrams per meter square and daunorubicin at 90 milligrams per meter square. And very consistently across these 3 studies, there's been improvements in the high-dose daunorubicin arm with regard to response rates, but then also survival measures. But of course, there's a fundamental problem, and that is, even in 2010, but certainly in 2016, the standard dose of daunorubicin is not 45 milligrams per meter square, but it's at least 60 milligrams per meter square. So this has raised a lot of debate as well. You're comparing something against a suboptimal standard. So what do we do with the data? So again, the MRC or NCRI, as it's now called, has addressed this exact question by randomizing, again, about 1,200 patients to daunorubicin of 60 milligrams per meter square or 90. And it's a little, so the trial scheme is a little different from the other trials, and there's a lot of randomizations happening later on, and really the difference is only 30 milligrams per meter square in the first of the induction courses. And that has been used to sort of say, well, it's not so surprising that when they looked in their data for the first time, they really didn't see a difference in outcomes. So the conclusion that was first published was there really is no benefit of high dose of daunorubicin. And again, critics have said, well, you're talking about 30 milligrams per meter square difference in one course of therapy. But just a few weeks or months ago, the group has published a subset analysis going back to their data and looking at the FLT3 patients, and show in this study that there is a small but at least statistically significant difference specifically for patients that have an ITD present. Now, a lot of the questions remain as like allelic ratio and other like details that in these days we probably would have and would like to have. But at least some hint that higher dose of daunorubicin may have some value for certain subsets of patients. I think any discussion about progress in AML in the last few years needs to include gemtuzumab, ozogamicin, or Mylotarg. which is a CD33 antibody to which a toxic drug from the calicheamicin family is attached to. And this toxin induces double-strand and single-strand DNA damage when the drug is internalized. The drug has demonstrated single-agent activity primarily in acute promyelocytic leukemia and APL, but many studies have shown that as a single agent, you can get up to a quarter or a third of the patients into remission when you give them single-agent Mylotarg, although in some of the series, this remission rate has been much, much lower than that. But based on these quote-unquote promising phase 2 studies, Mylotarg was approved on the fast-track pathway in the year 2000. And I think while for many years it remained somewhat unclear what the real value is of this drug, there's been a number of randomized studies that have identified a benefit during upfront therapy for AML. And I think the most important studies are a series of 5 studies, 4 of which conducted in Europe and 1 conducted in the US, that have collectively added Mylotarg to standard induction chemotherapy for newly diagnosed adults with AML. And overall, there were about 3,300 patients or so treated on these 5 trials. And even though the trials differ with regard to when exactly the drug was given, what dose was exactly given, whether it was just a single dose or there were split doses given, the outcomes were very consistent across these 5 studies. And there's been a meta-analysis done of these studies that sort of sum up the data by showing that the main benefit lies in a reduction in the relapse risk for patients, and with that an improvement in relapse-free, but also overall survival. But most importantly, this effect was not seen uniformly across all patients. It really was primarily seen in patients with favorable risk leukemia, with some benefit, albeit smaller, in intermediate risk leukemias, and not seen at all in patients with adverse risk leukemia. These data are complemented by a large study in pediatrics that shows somewhat similar finding, except that they saw a benefit across all the genetic groups. And there's also a randomized study just published recently where there's a really very, very small benefit when you just give patients this drug instead of best supportive care. But of course, the drug is currently, and I don't want to go into this for too much, the drug is removed from the market since 2010 in most countries. And even though there's rumors that the company is working towards bringing it back on the market, they're relatively tight-lipped with regard to when that actually might happen. So we're still waiting for that to occur. But in parallel to us trying to understand what the prognostic significance of all these mutations are, there's been a lot of work done trying to understand the functional consequences of these gene mutations in AML. And with this is of course a fruitful ground for rational drug development. And I think there's a first wave of these drugs that we now see in the clinic, and certainly consists with the fact that tyrosine kinase mutations are very common in AML. A first focus has been on using tyrosine kinase inhibitors, in particular quote-unquote FLT3 inhibitors in AML. And just to sort of highlight, even though you always hear about them to be FLT3 inhibitors, they're really sort of dirty inhibitors in some ways, in that they more or less affect other kinases, and this is shown of these sort of kinome diagrams where for example, PKC412, which is midostaurin, the drug on the bottom left, really has has activity well outside of the FLT3. And really, midostaurin is the drug that probably one should focus on most right now as the next drug to be approved in AML. This is based on a study that really was sort of a brute effort in demonstrating that you can do large trials with genetically pre-selected patients. This was a study done in 17 countries in over 200 sites, run over 3.5 years. or 4.5 years, that screened over 3,200 patients with AML for the presence of FLT3 abnormalities, and if they had either a point mutation or an internal tandem duplication, they were eligible to go on this trial that essentially used standard induction and consolidation chemotherapy and randomized patients to either placebo or midostaurin given along all these steps plus up to 12 months of maintenance afterwards. It was a stratified randomization that really led to well-balanced patients among these 720 or so overall on this trial. I think the main thing here is the efficacy. The addition of midostaurin led to a small difference in response rates, but much more importantly, it led to improvements in event-free, disease-free, and overall survival that were statistically significant and appeared in magnitude similar whether or not you censor patients for transplantation. And these are sort of curves I found from the ASH abstract when this study was presented last year. It was one of the plenary papers that were presented. Again, it's not a black and white difference, but there's an incremental benefit in these patients. What is interesting is that the benefit of midostaurin was seen in all the three strata of the patients. So whether a patient had a point mutation or a high or low allelic ratio ITD abnormality, the magnitude of benefit seemed very similar across these three strata. And again, I'm not sure this projects very well, but when you graphically map this out, this is reflected by these survival curves. Midostaurin was overall well tolerated. There were really only rashes that were seen more commonly in the midostaurin-treated patients. There was no increase in early deaths, although some of the early deaths with pneumonitis seemed somewhat unique maybe to midostaurin. But overall, the conclusion from this trial is that if you spend a lot of effort, you can treat, you can pre-select patients genetically and randomize to a large study. Midostaurin has a benefit, statistically significantly so, with regard to survival endpoints in newly diagnosed patients with FLT3 abnormalities. And when given so, it can be done safely and in a very tolerated fashion. And I think we generally expect that this trial will be sufficient for the FDA to approve this drug for AML, with sort of rumors and hopes that this might happen sometime early next year. What is interesting, though, is that the benefit is really seen across all these three patient subsets. And at least to me, this raises the question whether one would have seen a benefit also in FLT3 negative patients. And in fact, there's been another study, in this case using sorafenib, another tyrosine kinase inhibitor that has exactly tested that idea. So this was a smaller study of 280-ish patients, again younger adults with AML, that were treated in several sites in Germany, and they were undergoing their standard treatment for AML according to how their leukemia group treats patients. Huh? Okay. How much do I have left? Okay. And this study, unlike the trial before, was open for all patients regardless of FLT3 status. And this study also showed improvements in event-free and relapse-free survival, but not overall survival, which is really distinctly different from the midostaurin trial. Also different from the midostaurin trial is that sorafenib really has shown significant toxicity in these patients, with particularly GI toxicities and bleeding being sort of the dominant toxicities. So this is a second trial that suggests benefit for tyrosine kinase inhibitors in newly diagnosed AML patients, this time suggesting the benefit may extend beyond patients with FLT3 abnormalities. But it's a drug that has significant toxicities. So choosing it is becoming a much more difficult to do. And in fact, there's been a study done in older adults, age 65 and above, where there was no difference in outcome, primarily because of increased toxicity in these patients. Five more minutes. There was a few snippets I wanted to highlight outside of the newly diagnosed treatment arena. We're still working on refining transplantation things. I think for transplantation, there's now randomized studies that look at some of the fine questions, as how much conditioning intensity one should use. And there's emerging data for the use of checkpoint inhibitors in post-transplant patients, although it scares transplant as a way because of the potential for increased GVHD. I think MRD, when it comes to discussions pro or con transplant, MRD can be very, very valuable in helping you make decisions. And with this, there's also renewed interest in autologous transplant because we're recognizing sort of low-risk patients that may not benefit from allogeneic transplant that much. I think just one last word on the few patients that may be candidates for non-intense therapy. I think here really the strong recommendation is to consider a clinical trial, if at all possible. I think de facto in the US, the standard has become either azacitidine or decitabine. But when you look at the survival curves for patients, and this is from a large study published last year, with survival in the range of 10 to 12 months, the outcomes are really not very good. And one should strongly consider doing something in addition to that. I think on the horizon, there's a number of things that are not ready for prime time, and hopefully in the next few years we'll hear more about. These encompass both new antibodies, adoptive immunotherapy, small molecule drugs, and other things. So to summarize, I think the molecular landscape is now very well characterized. This is now the time to sort of figure out how we can use all this information to better risk stratify patients and come up with rational treatments. 7+3 sort of remains the standard for many patients, many institutions, but there are incremental advances over this, maybe with high dose of cytarabine, addition of high dose of anthracyclines, antibodies, or small molecule drugs. And again, I really need to pitch this idea to strongly consider clinical trials for our patients. And if you're thinking about transplantation, do this early in the treatment course so that the timing works out nicely. Thank you very much. Okay.